Hello and welcome back to the Rheumatology.physio podcast. So this month we have a really exciting podcast that I recorded a couple of nights ago now as I'm recording this introduction with Professor Bhaskar Dasgupta. And he is a really eminent rheumatologist, and he was very gracious giving up his time to have a chat with me. Professor Dasgupta is a professor of rheumatology at Southend University Hospital, and he has a lifelong interest in PMR and GCA. And during the chat, you will notice some really cool things that he has done over time with regards to setting clinics up and innovating in the space of polymyalgia rheumatica, rheumatology, and musculoskeletal practice in general. So super fascinating. Just before we do get into the chat, a couple of things that I want to steer your attention to. I am going to try and do a few more of these interview type podcasts. Hopefully we'll be able to get Mike Dare onto some of them as well. Unfortunately, he was unavailable for this recording, but fingers crossed he will bring his lovely South African accent onto some of the recordings in future. I'm also going to branch into trying to do some live streams, hopefully one of those a month, just commenting on things that have been in the media or interesting research or things that I've learned. And of course, we will continue to do the blog reads as well, coming through the podcast platform. So please do hit subscribe on any podcast channel that you may enjoy using. And also finally, just before we get into this chat, I have now finally succumbed to popular request and built a Facebook page for Rheumatology.physio. So just type Rheumatology.physio into Facebook and you can follow it there if that is your preferred social media platform. Of course, we're still on Instagram and Twitter, which I am endeavoring to use Instagram and Facebook just as often as I get onto Twitter. So please do go find it there. So I'm going to leave us into this amazing chat, so much detail on polymyalgia rheumatica, a really challenging diagnosis, and Professor Dasgupta makes it so much easier and hopefully clarifies a ton of things for all of those of you, especially in first contact practitioner roles, but also private practitioners, MSK, assessment clinics, all those kind of things. This is going to be super helpful. So enjoy the chat and I'll see you on the next podcast. Brilliant. So I'm here today with Professor Dasgupta, and I'm absolutely delighted that he's come on to join me to talk about some things regarding polymyalgia rheumatica, and we're going to try to unravel some of the myths and help physiotherapists and musculoskeletal practitioners to recognise, onwardly refer as appropriate, and maybe even manage a little bit as well, although that's a difficult topic for us at the moment, and then hopefully get some good information so we all understand the condition a little bit better. So the first thing, would you just introduce yourself a little bit to the listeners? And you've got an amazing career to date. You've done some brilliant things and continue to do so. So just a quick introduction to yourself, if you don't mind.
Thank you very much, Jack, for inviting me to your podcast. So yes, I'm Bhaskar Dasgupta. I'm a consultant rheumatologist, and I've spent all my working life at Southend University Hospital in the rheumatology department, and most of it has been treating lots of general rheumatological conditions, but I've always had a very, very special interest right from my training days in two conditions, polymyalgia rheumatica and giant cell arthritis. And originally, when I was a trainee at Guy's Hospital as an arthritis research council trainee, I worked on polymyalgia rheumatica, giant cell arthritis, and I was very lucky to be the first to describe raised levels of interleukin-6 in these two conditions, which is now, of course, being used to treat these conditions, giant cell arthritis with tocilizumab. But I've maintained that interest in these two conditions. And over the years, we've published lots of interesting papers, including the BSR guidelines on PMR, BSR guidelines on GCA, we published the EULAR ACR guidelines for a diagnosis of PMR, the classification criteria, the treatment guidelines, and of course, we've had a lot of luck in developing the fast track approach to GCA, ultrasound guided diagnosis of GCA, and have had a personal involvement in bringing tocilizumab to patients with GCA in the United Kingdom, amongst many other things. And most recently, we have described the HALO score, which looks at the quantification of ultrasound in the diagnosis and assessment of GCA, so, and the probability score. So yes, life has been very busy looking at research and the treatment of PMR and GCA. Thank you.
And you say luck. I think there's been quite a lot. You're being very humble there. I think there's a lot of intelligence, skill, and hard work to be put in to achieve all of those things. I think, and certainly the parts that I've involved myself in is not the right word, but read the guidance and things that you've been published in is amazing. And I think that rheumatologists as a whole, obviously I'm biased, which is the specialism I've chosen as well, but rheumatologists to me do seem very passionate and get very involved in the research and making sure they do the best for their patients. I just wondered about, with regards to PMR and GCA, have you had much involvement with physiotherapists and MSK sort of practitioners as well, or do you feel like it's been more of a rheumatologist and rheumatology nurse-led process that you've been down?
That is a very, very interesting question, Jack. And I perhaps I might be wrong, but I think that we were the first to describe the entire term musculoskeletal. The first musculoskeletal clinic, certainly one of the first musculoskeletal clinics in the United Kingdom, was the clinic that we set up at Southend University Hospital, where I worked alongside a consultant physiotherapist, a very good, highly trained consultant physiotherapist. We developed the musculoskeletal clinic, and what we did was that we tried to apply the same tenets, the principles that we had advocated in the BSR guidelines on polymyalgia rheumatica. For example, looking at people with shoulder pain from different conditions. And then we saw these patients in the musculoskeletal clinic, and the musculoskeletal part was dealt with, and patients who had more medical problems as PMR were the ones that I got involved with much more. So right from inception, I've always advocated that we must have multidisciplinary team, and that includes rheumatologists, that includes physiotherapists, that includes nurse specialists.
Yeah, brilliant. And it's fascinating to understand that process as to how that was developed. That's amazing. I think we spoke just before we started recording that personally I feel like I've come quite late in my journey to polymyalgia rheumatica as something where I spent a lot of time trying to understand rheumatoid arthritis, a lot of times axial spondyloarthritis and those kind of conditions. And I feel like only relatively recently have I sort of turned my attention to polymyalgia rheumatica. Do you feel like, in your experience, that's something that outside of the rheumatology environment, it does get a little bit forgotten about as a condition and a little bit ignored, or what do you think?
Well, I think that's a very interesting question. I do feel that polymyalgia rheumatica suffers from problems with diagnosis. And by that, I mean, at the same time, it is underdiagnosed as well as being overdiagnosed. So often we get other conditions being labeled as polymyalgia rheumatica and treated with corticosteroids, leading to an overdiagnosis of the condition. And yet, when patients present with real, genuine polymyalgia rheumatica, that often gets underdiagnosed and either left alone, or doctors, nurses, physiotherapists, they keep searching for other diagnoses where the diagnosis of PMR is being missed. So yes, I think it is very important that physiotherapists keep in mind the diagnosis of PMR. For example, when you're dealing with patients with shoulder problems and with rotator cuff problems and capsulitis, the very fact that, for example, a patient has got bilateral shoulder pain should alert the physiotherapist, should alert the GP that they're dealing with a condition which could be polymyalgia rheumatica. So yes, I feel it's very important that musculoskeletal practitioners, such as physiotherapists, should be very much aware of this condition.
Yeah, I mean, I totally agree with you, which is why we're having this conversation. I think one of the things that really interests me, and I'd like to get your opinion on, is this this overdiagnosis, because I think there's obviously both sets have a problem, but when you look at patients, let's say someone's got fibromyalgia and you start treating them with the corticosteroids, it tends to be a big problem. So what do you feel like where do you feel like the reasoning process falls down in either with GPs or physiotherapists that lead them down that route? What is it that they obviously make a step they shouldn't have made? What is that reasoning step, do you think, most commonly?
I think first of all, GPs, physiotherapists really need to sharpen up the definition of polymyalgia. And really, to put it in very simple terms, I think of the polymyalgic syndrome. And by polymyalgic syndrome, I mean what's called a proximal pain and stiffness syndrome. So, polymyalgia, it's not any old aching. It has to be shoulder and hip girdle aching along with stiffness. So you must have a bilaterality of pain. Shoulders must be involved, hips usually always involved, and they must have early morning stiffness. So if you define polymyalgia in those terms, you're unlikely to, for example, overdiagnose fibromyalgia, because if you then take specific history, you will find out that patients with fibromyalgia don't have bilateral shoulder and hip girdle pain with stiffness. And you can then make a diagnosis of fibromyalgia. But the important point that Jack, I talk about is some of what's called the 10 top tips in the making a diagnosis of polymyalgia. First of all, you need to recognize that the polymyalgic syndrome does not mean PMR. So many conditions can ache, can have proximal aching and stiffness, and yet not be PMR. So that's the first thing. And amongst them, you have to think of the rheumatological conditions. You have to think of, mechanical shoulder conditions, such as rotator cuff, such as capsulitis. You have to think of chronic pain. You have to think of more serious infections, deep-seated infections, and cancer, because those also come into the differential diagnosis. And you've got to think of metabolic conditions. For example, people with endocrine problems, thyroid overactivity, underactivity, other neurological problems. They can also cause musculoskeletal aching and stiffness. So you need to recognize what's called the polymyalgic syndrome and then define PMR very specifically. Now, there are some clues. For example, PMR rarely occurs under 65, although we say that it can occur above the age of 50, but generally in the 50s, it's not very common. So if you limit the suspicion of PMR to people above 65, you're more likely to be right than wrong. If you then define PMR as bilateral shoulder pain, so it has to be new onset. So in fibromyalgia, for example, you will see that patients have had the symptoms for 5 years, 10 years, 15 years, whereas PMR is an abrupt condition. So patients will actually tell you, Doc, I started aching on the 5th of January, literally as precise as that. So PMR is a bilateral new onset shoulder pain. And also, if you all agree that we don't diagnose PMR unless you have raised inflammatory markers. So I know there are case series where PMR has been diagnosed with normal blood tests, but that's very, very uncommon. So one should really make sure that the blood tests show raised inflammation, by which I mean, for example, the CRP has to be at least above 10. And very, very important, you need to make a specific search for non-PMR clues. And by non-PMR clues, I mean some simple things. Number one, you should try and make sure that you don't diagnose PMR in younger patients, because more often than not, you're likely to be wrong. Younger patients are likely to have other conditions. Number two, make sure that you don't diagnose PMR in patients who've got spinal problems. Now, PMR generally affects the shoulders, affects the hips, rarely affects the spine. And I have seen in my practice lots of patients with serious or less serious spinal conditions being diagnosed as PMR. PMR rarely occurs in the absence of shoulder pain. So if a patient comes to you with aching around the hips without the shoulders being involved, take it from me, that's not PMR. You need to be thinking of specific hip conditions. You need to be thinking of pelvic conditions. You need to be thinking of lower spinal conditions, circulatory problems, and all those things can be misdiagnosed as PMR. So generally, without shoulder pain, don't diagnose PMR. There are other important features. Not to diagnose PMR if your blood tests are totally normal. So if your CRP is totally normal, ESR is totally normal, don't diagnose PMR. If you have very high CRP, very high ESR, don't diagnose PMR. So because it's more likely that patient is going to have a more serious condition like infection, like cancer, something else. It can happen that that patient has PMR, but it's unlikely. So generally, men again are not always, liable to have PMR. We know that women get it more often than men. So I make a more scrupulous, scrutiny for other conditions. If men present to me with symptoms that might look like PMR. So first of all, you need to have a approach which excludes other conditions in a stepwise manner. So you need to include people with new onset bilateral shoulder pain, raised inflammatory markers, older patient, and then stepwise you need to exclude infection, cancer, GCA. Now that is a very important condition. So giant cell arthritis, of course, is a condition which we treat with higher doses of steroid, and it can have other complications. But many patients with giant cell arthritis also get polymyalgic symptoms. And when these patients with GCA get polymyalgic symptoms, the patient then goes to the doctor or the physiotherapist or whoever, and they don't talk about their headaches or GCA. They talk about the fact that they can't move and they're getting aches and pains and stiffness. So they get misdiagnosed as PMR. And in fact, actually, the patient has GCA. So you need to make sure that the patient doesn't have GCA, infection, cancer, rheumatological conditions, but you need to make sure that you're not over-treating a less serious condition like fibromyalgia, because most patients will respond to steroids. So you give these patients corticosteroids and they all respond. And steroid response is very, very non-specific. So, there's this mythology in the medical literature that PMR is a steroid responsive disease. It is. It does respond to steroids, but many other conditions also respond to steroids. And more importantly, serious conditions can respond for a few days, few weeks to steroids. So one has to be very, very circumspect. More importantly, you need to do a basic set of blood tests before you pick up the pen and prescribe steroids. And these blood tests are very simple. You need to do their blood count, you need to do their kidney, you didn't need to do their liver function test, bone profile, calcium, vitamin D, CRP, ESR, the rheumatoid tests, because rheumatoid arthritis, often in the older patient, can present as PMR. So you need to check the rheumatoid factor, anti-CCP. And once you've done your basic tests, which also includes some endocrine tests like the thyroid function, once you've done these tests, once you've seen the results, and that's when you actually treat the patient with corticosteroids. Now, the big mistake that doctors often make is to make a diagnosis of PMR, start the steroids, and then do the blood test. And that's useless because the steroids have a big effect on the blood tests. So if the diagnosis is PMR, if there is no hint of GCA, I would advocate that we wait and we get these tests back, look at these results, and then start steroids. And one very, very important precaution that we need to take is the dose of steroid. So starting patients on high doses of steroid is not a good idea. So higher the dose of steroid, the more non-specific the response. So you need to start on a lower dose. And in PMR, we have worked out that 15 milligram prednisolone daily is more than adequate for most patients. Sometimes we may have to go up to 20 milligrams, but basically 15 milligrams works for 90% of our patients. And you start them on steroids, and then within a month, you get them back, and then you evaluate their response. And when we talk about response, we are talking about pain, their global response, their stiffness, but very, very important to analyze their disability. As a physiotherapist, you must know a lot about disability. And disability in PMR actually gives you the clue about what you're dealing with. For example, patients with PMR may not tell you that they are stiff, but what they'll tell you is that they can't get out of bed. So they have a disability with rising. They can't reach to get something above their head or pick up something from the floor. They can't dress or undress. These are things that they do first thing in the morning. They can't get on and off a toilet. So hygiene is impaired. They can't walk. So if you took these simple 5 questions, rising, reaching, dressing, undressing, hygiene, and walking, you will pick up most of your patients with PMR. So we need to be looking at function. So then you see these patients after a month, and you look at their global response in terms of pain, stiffness, disability, and also you look at their blood markers. And generally, if it is PMR, you will find that the inflammatory markers have shown at least a 70% improvement. So that's what I keep talking about, is that you need to have a 70% improvement in pain, 70% improvement in stiffness, 70% improvement in inflammatory markers. And once you've got that, then you can make a proper diagnosis of PMR and follow that patient up on a regular basis. So these are some of the ways, the strategies that one has to prevent overdiagnosis on one hand and underdiagnosis of the condition.
Yeah, for sure. And you phrase all that, that's such good information, the way you phrase that as well, because I think it's a really nice way of setting things out. Like you said, because I can imagine from your point of view, let's say someone diagnoses polymyalgia rheumatica in the GP surgery or something, and they provide them steroids before they do bloods, and they don't wait a month, and they don't see what their response is like. And then the patient doesn't respond to steroids, and they go, oh, I don't know what to do with this patient now. I better refer them to the professor. And then you pick them up with this sort of mess where they're on steroids, so it's suppressed their bloods and whatever else is going on. And then I suspect you're then sort of trying to find a needle in a haystack because you haven't got the information that you would like to base that diagnosis off then. So it really needs to be, as you said, that stepwise fashion. I was wondering about at what point, because if I can imagine that rheumatologists don't want all these polymyalgia syndrome patients referred to rheumatology clinics, otherwise you'll sort of drown in them. So at what point would you say that the patient needs to then go on to rheumatology for further either investigations or management plans? I'm assuming it's not at that point if they've responded to the 70%. But is there anything in those stepwise fashions, either early on or at that month point, that you would say then is a good indicator to be referring to rheumatology?
I think that's a very, very good point. You can take two different approaches to it. And sometimes I feel that if we could make an early diagnosis and make a diagnosis of PMR, confirm it, and say, yes, that is indeed PMR, and endorse a management plan, then rheumatologists actually could have a diagnostic clinic, a sort of a fast-track PMR clinic, where you saw these patients, confirm the diagnosis, and send them back to the GP, say, yes, use 15 milligram prednisolone. This is the British Society of Rheumatology tapering guideline, and this is what you monitor, and send them back if you need to. So that is one way forward. So you saw the patients, made a diagnosis or excluded that diagnosis of PMR, and made a management plan for the patients with PMR and send them back to the GP. But what usually happens is actually the GPs often may hang on to this patient. And, the typical referral that we get is this patient presented with this condition, say a year ago. We started steroids and the patient responded initially. And now I can't get the patient off steroids. They're still stuck at 10 milligram prednisolone. What should I do? And I often write back saying that, what do you expect me to do? And the correct way is somewhere in the middle. I would think that if a GP or a physiotherapist who had interest in PMR saw a patient with typical PMR features in the older patient, around about 65, 70 or older, abrupt onset of symptoms, typical bilateral shoulder pain, raised inflammatory markers, most importantly, ran through the non-PMR clues, infection, cancer, GCA, rheumatological conditions, chronic pain, metabolic condition. So did the blood test and didn't pick up anything else on the blood test. Made sure that other PMR mimics were not missed. At that point, I would say that you could start the patient on 15 milligram prednisolone. And if the patient has more than 70% response without any other clues for a non-PMR diagnosis, I think that patient could be managed without being referred to rheumatology. But that is something that requires training. And it needs a change in clinical practice because people don't deal with PMR in primary care in that way. And so it's quite important. And the reason I'm speaking to you is that I think training of musculoskeletal specialists, of general practitioners in the approach to PMR is absolutely vital. Because, people underrate the fact steroids are full of side effects. And, what the person who prescribes the steroids doesn't realize that today the patient might be very happy with the steroids, go away, fantastic response. 2 years down the line, then they are actually facing the side effects of long-term steroids, such as diabetes, such as osteoporotic fractures, such as hypertension, such as eye complications, such as muscle problems, such as skin problems, such as mood problems. A big problem with the older person with steroids is it causes depression and it causes sleep disturbance. So, name it and you get it with corticosteroids. So it's all about training the musculoskeletal practitioner, the GP, to recognize PMR, to assess PMR correctly. And if you can do that, rheumatologists don't need to see every patient referred. On the other hand, if there's a problem with training and we know that we can't actually rely on everyone diagnosing PMR correctly, then a case can be made for having fast-track PMR clinics which confirm or exclude the diagnosis of PMR and then send them back to the person who is referring, saying that, yes, this is PMR, this is how you should treat it, or no, this is not PMR, and these are the things that you additionally need to do.
Yeah, for sure. And I'm going to make an assumption as well that occasionally there is some diagnostic uncertainty. I remember on the webinar that I watched with yourself, you mentioned that a not insignificant number of PMR patients will have some peripheral synovitis as well. And when you've got predominantly ladies, I suspect that there's a number of them who present with PMR who also have something like hand or osteoarthritis, with that being so common, that there will be those cases where there's some diagnostic uncertainty, where people are sort of flipping between, oh, maybe it might be a rheumatoid arthritic presentation compared to a polymyalgic condition, where that would be a good referral into rheumatology as well, just to make sure.
Yeah, absolutely. So in terms of definite referrals into rheumatology, diagnostic uncertainty is very important. And certainly, if you're not sure about the diagnosis, you should never just throw steroids at that. And because that's what people do. There's a term that people use called atypical PMR. Atypical PMR does not exist. Is it PMR or is it not? And if it is not PMR, you have to try and find out what it is. The fact about the peripheral synovitis is more difficult because we actually don't understand very well, even now, where polymyalgia ends and where inflammatory arthritis begins. We just don't understand. So polymyalgia is a clinical syndrome, and it sits between two poles. On one hand, you have vasculitis, as giant cell arthritis. On the other hand, you have inflammatory arthritis. So, and polymyalgia is somewhere in between. So you have to, in your clinical assessment, make a judgment. Is it polymyalgia on its own? Is it polymyalgia with giant cell arthritis? Is it polymyalgia more going towards inflammatory arthritis? Now, and it can be all three. And sometimes only time tells that you follow that patient and then the patient develops other symptoms. And certainly, if you feel that this is not just polymyalgia, but has a smell of GCA or has a smell of inflammatory arthritis, you must refer this patient. Because then it's not just about steroids, you need to start thinking of other medications to give them, methotrexate or flunomide, or assessment with imaging, PET scans, ultrasound scans, etc., to look for other conditions. So diagnostic uncertainty is an absolute category of referrals to rheumatology. There is another important category of referrals to rheumatology, what we call relapsing PMR. So a patient initially responds to 15 milligram prednisolone, but as you gradually reduce the dose of steroid, you find that the patient starts relapsing. And the patient has more symptoms, has more stiffness, the inflammatory markers go up. And the inflammatory markers, may have gone down, and then they suddenly again start going up. And that persistent raised inflammatory markers with relapses as a definite referral to the rheumatology department. One important symptom that I didn't mention, what I call as constitutional symptoms. Constitutional symptoms, I mean weight loss. I mean drenching night sweats or day sweats, or low grade temperatures. And all those things can occur in PMR. And if you have predominant constitutional symptoms happening regularly, rest assured that you might be dealing with something else, either GCA or something more serious like infection, like cancer. One big form of cancer that actually often mimics rheumatological conditions is lymphomas. So lymphomas can often be very slow growing, and they can have lots of constitutional symptoms, what's called B symptoms. And, and they can respond to steroids. Lymphomas respond to steroids. You may find that these patients who initially respond to steroids but relapse quickly as you reduce the steroid. So relapsing PMR is a very, very important indication for an immediate rheumatology referral. So diagnostic uncertainty, presence of non-PMR clues, relapsing PMR, where the patient is not getting better. Also, the presence of other comorbidities. Patients often come as a package. They have other medical conditions. Whether they have cardiac condition, they have a renal condition, they have diabetes, they have osteoporosis. So if a patient with all these other medical conditions develops PMR, you may need to refer that patient. If the patient has got risk factors to corticosteroids, if there is history of osteoporotic fractures, if there's a history of diabetes, if there's history of hypertension, etc., where steroids may not be as safe as you would like, you must refer. So these are some of the indications for referral: diagnostic uncertainty, relapsing PMR, presence of comorbidities, a presence of risk factors to corticosteroids. And of course, there are patient-specific factors. Sometimes, a patient is different from another one. So when you're not quite sure about compliance, adherence, regular precautions about avoiding steroid side effects, and that is also a definitely indication for referral. One important indication for referral may be just about education. Sometimes to clear the air about the condition, about the treatment, you might just need another second opinion, and there's nothing wrong with that. So that more or less covers the different conditions, different indications for a rheumatology referral.
Brilliant. I mean, I could talk to you all night, but I just wanted to qualify just a little bit on one of those things you just said. You said about the relapsing PMR. When you brought the steroids down, would you advocate for the referral onwards if their symptoms return that first time, or would it be a case of try again for a second time to bring the symptoms down, or would it be refer to rheumatology immediately as soon as they get the symptoms come back after the steroids titrate?
Well, yeah, it depends on to what extent they had control of the symptoms on steroids, and to what extent they had the relapse as you lower the steroids. So in the first instance, if you're dealing with an appropriate age group, say a 70-year-old lady who has typical PMR symptoms, with the crazy inflammatory markers, has got no other non-PMR clues, and you give her 15 milligram prednisolone, and you've had a 70% response after the first month's assessment in terms of pain, stiffness, inflammatory markers, which have become normal, and then you continue reducing the steroids, and then you find that the patient develops pain, stiffness, raised inflammatory markers. So I wouldn't think that that's an indication for referral. You may wish to go back to the previous higher dose of steroid that worked for that patient. So we normally say 15 milligrams for 3 weeks, 12.5 milligrams for 3 weeks, and then 10 milligrams prednisolone. And so basically at week 6, they should be around about 10 milligram prednisolone. And then you gradually start reducing further. And with that gradual reduction of steroids, if they have a minor flare, previously they have responded very well to the steroids, and there's no other question about diagnostic uncertainty. I would say that just put up the dose of steroid back to the previous dose and see how this happens. But I would say that more than one flare should be an indication for referral. On the other hand, if a patient right at the start you were not quite sure about and had non-PMR type of clues, some diagnostic uncertainty, and you had some response to say 15 or 20 milligram prednisolone, as soon as you started reducing the dose of steroid, patient has a flare. I think in that sort of situation, it's better to refer that patient early.
Perfect. Yeah, brilliant. Absolutely spot on. That's answered my question to the T. That's brilliant. Well, I don't want to take up any more of your evening. I'm very grateful for you to have a chat with me. I'm going to, when this goes out, I'll link to all your educational webinars that you do, so that anybody can seek those out if they want more information, because the depth that you go into is mind-blowing, and I must admit that I'm frantically writing notes as I'm listening to you talk about these things. So it's yeah, really excellent. And I'll pop in your social media and all that kind of thing as well, so people know where to find you. But once again, thank you very much for having a chat with me, and maybe we'll get you back on again to talk about GCA at some point as well. That'd be great.
Absolutely. I'd be very. In fact, I'm doing a webinar end of this month on the approach to GCA. So that's another very tricky condition, and with big cost if you get it wrong in different ways. So yes, yeah, that's fine. Is there anything else that you wanted to ask?
Oh, thousands of things, but I'll keep them for another time, I think, because otherwise we'll have a 10-hour podcast and no one will get to the end of it. So we'll just get you back and ask some more questions, I think. Well, thank you very much. I really enjoyed that chat. I think it's going to be really useful.
Thank you very much. Thanks, Jack. And
brilliant.
You're doing some great work, and all the best.
Thank you very much. Have a good rest of your evening.
Yeah, thanks.
Thanks. Bye.